Hello, everyone, and thanks for joining us for this alert webinar. We'll just wait a moment to everybody to join us by logging in. Thank you. Well, good evening, everybody. My name's Louise Kohlmeyer, and I'm the Director of the Alert Program at Macquarie University. Welcome to this webinar entitled Breast Cancer Rehabilitation, the Importance of Being Early and Alert. So we need you to stay alert for the next hour and a half while we debate and have discussion around this really important topic. For those watching live, thank you for joining us in person. And for those who are watching a recording, we welcome you as well. So I would like to acknowledge the traditional custodians of the Macquarie University land, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the time of creation. We pay our respects to elders past, present and future, and also acknowledge the lands that you may be watching this recording. So I'd like to introduce our speakers for this evening. We have 4 speakers who are going to be joining us, and we're going to, rather than waste time in between the speakers, I'm going to introduce them all to you first, and then we will really enjoy listening to their presentations. So our first speaker is Dr. Negin Sedaghat. Negin is an Australian specialist general surgeon with subspecialisation in breast surgery and surgical oncology, as well as endocrine surgery. She is Breast Surg ANZ certified in breast surgery and awarded professional certification with distinction in oncoplastic breast surgery from University of Sydney. Negin specialises in breast cancer and breast health, including a wide range of complex oncoplastic and reconstructive surgery, breast symmetry surgery, thyroid and parathyroid gland surgery. She also works in skin lesions, lumps and hernia repairs. Her contemporary and compassionate approach occurs within a patient-centred care practice, together with comprehensive multidisciplinary teams here at MQ Health at Macquarie University. Welcome, Negin. I'd also like to introduce Dr. Stephanie Lam. Steph has a Bachelor of Applied Science in Physiotherapy from the University of Sydney and a medical degree from Notre Dame. She is a Fellow of the Australasian Faculty of Rehabilitation Medicine and a member of the Australasian Lymphology Association. She has a wealth of experience as a rehabilitation physician, having worked in both private and public hospitals. Steph has joined us here at Alert as our new medical fellow and will provide comprehensive case management of patients with lymphedema, lymphedema, and other chronic edemas within the Alert Clinic. Steph works closely with Dr. Helen Mackey, who many of you will know, and our multidisciplinary team of dedicated and caring professionals. Welcome, Steph, and we're so glad that you're joining our team. I'd like to introduce Fiona Tisdall-Blake. Many of you will know Fiona as a physiotherapist graduating from La Trobe University. Fiona is a member of the Australasian Physiotherapy Association and the Australasian Lymphology Association, the ALA. Fiona is an experienced physiotherapist with a broad range of clinical settings, including private practice, occupational health, and hospital settings in Australia and the United Kingdom. Fiona joined our Alert program in 2017 and qualified as a lymphedema therapist in 2016 through the Alert accreditation program. As a qualified lymphedema therapist, Fiona brings extensive experience in orthopedic, neurological, and spinal surgery rehabilitation to her management of lymphedema. I'd also like to welcome and introduce Mandy Galbraith. Mandy is the Clinical Support and Customer Solutions Manager at Medi Australia. She has a nursing background and is lymphedema trained through our Alert program. Mandy is passionate about supporting therapists to provide the best fitting garments appropriate to the patient's needs. She runs made-to-measure workshops and enjoys problem solving for better outcomes. Certainly a lineup of fantastic speakers for this evening's webinar. And with us, we have a combination of lymphedema therapists, occupational therapists, physiotherapists, registered nurses, massage therapists, breast care nurses, medical practitioners, exercise physiologists, and I'm sure others. We welcome you all to this webinar, and we ask you to put in questions, any questions you have throughout the presentations in the Q&A function, and we will certainly have time for discussion at the end of the presentations. So over to you, Negin, as our first presenter. Thank you.
Thanks so much, Louise, and I'm so happy to be able to engage in this important topic tonight. So we'll go to the first slide. So as we know, breast cancer is the most common malignancy in adult females, and for more than 90% of women, surgery is an important part of their treatment. Surgical therapy involves breast surgery and, when indicated, surgery to the axilla as well. Breast surgery includes lumpectomy in the form of breast conservation surgery with or without oncoplastic techniques, or mastectomy with or without reconstruction. Where axillary surgery is indicated, that can include sentinel lymph node biopsy, targeted axillary dissection, or an axillary lymph node clearance. And what we know is that surgery is a highly effective treatment in achieving disease control in women with breast cancer. Next slide. We also know that surgery can result in physical and psychosocial effects as well. And these effects may last for months or potentially years after treatment. The regional post-operative effects include lymphedema, pain, axillary web syndrome, and upper quadrant dysfunction, really defined by a loss of strength and range of motion, particularly in the shoulder. Whole body adverse effects include most notably fatigue. We know as well that the severity of these adverse effects varies, and it occurs across a continuum, where for some patients they may have none or mild effects, whereas other patients might have such significant effects that it impacts on their quality of life. And what we know is that it's dependent on a number of factors, which include age, comorbid conditions, treatment regimen, and baseline physical well-being. And what you will note from this is that some of these factors, such as age, is something that we can't modify. But another factors, say baseline physical well-being, is actually modifiable, and we could potentially influence that. As a surgeon, the top priority is to achieve the best outcomes for patients from surgical treatment. So these potentially modifiable factors that potentially could influence the outcome of surgery are very important to consider. And it leads me to the evolution of the surgeon. So historically, the surgeon was really an individual working within a silo. But now, as we're moving towards greater complexity, which is being driven by highly individualized treatment regimens, the modern surgeon is definitely a member of a comprehensive cancer team. Next slide. And so what does this breast cancer team look like? Well, it might look something like this, and definitely at least the cancer team consists of the breast surgeon, medical oncologist, and radiation oncologist. And definitely the leadership provided with the team can be variable, but certainly in Australian practice, I believe that it is the breast surgeon that commonly provides this leadership. And it's mainly because when a patient is diagnosed with breast cancer, the first breast cancer specialist that they're generally exposed to is the breast cancer surgeon. And it's really at this initial consultation where the patient appreciates an understanding of their treatment trajectory and potentially who might be involved in their breast cancer journey. Next aspect. And as we delved into the evolution of the surgeon, the breast cancer team has also evolved to more complexity and comprehensive care, including physiotherapy, occupational therapy, rehabilitation, and nutrition, and social services, to name a few. And this is because we're facilitating this highly individualized care because we know that it's associated with best outcomes. So if we were to piece all of that together, the modifiable factors, the surgery, and the team, it naturally concludes that facilitating the best outcomes from surgery starts before surgery, and that the imperative is to have a multidisciplinary approach from the beginning. So in addition to an excellent operation, the surgeon must also be excellent at utilising multidisciplinary expertise. And what are some of the potential things in which this multidisciplinary approach may look like and may enable? Well, firstly, it'll enable baseline holistic assessment, both in terms of the clinical disease characteristics, but also the physical well-being and psychosocial well-being of the patient. And as those baseline holistic assessments are made, it allows for identification of the health needs of the patient and thereby refinement of the treatment pathway as well, because identifying the health needs unique to each patient implies a very unique treatment pathway. So you can imagine that as the patient is engaging in this baseline assessment and identification of their health needs, it leads to an improved understanding of their health and cancer journey as well. Traditionally, what we may expect the patient journey to look like is that there's an initial consultation, and then it proceeds straight away to surgery with an associated recovery and long-term follow-up. But if we were to add in the multidisciplinary approach from the beginning, it might include baseline measures as well as actions. Next slide. Both in nutrition, physical exercise plans, as well as the psychosocial well-being. Next slide. So what does this all imply for a patient's recovery and long-term outlook? The evidence suggests, and this is cumulative evidence, both in patient groups affected by breast cancer, but also patient groups affected by other cancers, that where there is higher levels of preoperative aerobic fitness, it is associated with decreased postoperative complications and potentially improved disease-free survival. Where there is baseline body composition assessment with regular surveillance on follow-up, it allows for earlier identification of lymphedema with better therapeutic outcomes. And where there is high levels of psychosocial well-being, it's associated with higher satisfaction reported by patients after surgery as well. So the role of the breast surgeon is twofold, one within the operating theatre and the other within the multidisciplinary team. And what's really important to acknowledge is that this is a space which is associated with a current burgeoning of research. And certainly the understanding with respect to how best prepare patients before surgery is evolving. And there's still so many questions that we need to answer, which future research will address with respect to the different regimens and in particular the optimal regimen in the lead up to surgery. But ultimately, I do believe that it is the surgeon who takes leadership both in the operating theatre and within the multidisciplinary team to facilitate multiple expertise and specialists involved in the breast cancer care of a patient to facilitate the best outcomes for patients. So we'll be exploring that further, and I'd like to hand over to Dr. Stephanie Lam. Thank you.
Thanks, Dr. Sedaghat. I'm really excited to follow on from your talk because I think it will tie in really nicely with what you've been talking about. So we'll get started. Thank you very much, Louise. So I'll just start with, I guess, a definition of rehabilitation first, because it's defined by different people in lots of different ways. So I've taken my definition from the Faculty of Rehabilitation. So rehabilitation includes interdisciplinary teamwork, which will include allied health as well as nursing and medical practitioners, including the patient specialists and GPs. It's about providing coordinated, patient-focused, individualised programs of goal-directed rehabilitative care. So again, very much in keeping with what Dr. Sedaghat has been talking about, but what I'm going to do is give this a little bit of a rehabilitation spin, being a rehabilitation physician. So there is a role for rehab in the pre, peri, and post-op cancer treatment, which has been clearly established from Dr. Sedaghat's talk. And the aim is to identify and reach realistic goals with the patient in terms of their functioning and quality of life, as well as to monitor and manage any complications that occur throughout not only the rehabilitation context, but also the patient's cancer journey. And what we want to do is ensure holistic care of the person and to keep them at the centre of their care. Next slide, please. Thank you. I just wanted to introduce everyone to this framework for critical thinking. I'm a bit of an apostle for this framework. It's been created by the World Health Organization in 2001, so it's quite an old framework now, actually. And it's the International Classification of Functioning, Disability and Health. And the reason why I like this framework is because we don't stop thinking at the health condition. So if it's breast cancer, for example, back in the day in university, we'd often learn about the health condition, the anatomy, the physiology, its investigations and management. And often our learning might stop there. But what this framework encourages us to do is think about how the health condition is affecting the person's body functions and structures. So whether it be pain, shoulder and neck range of motion, reductions, fatigue, malnutrition, whatever the changes in body function are, it then encourages us to link this with the person's presentation, whether it be them presenting with difficulties with mobility or difficulties with performing their activities of daily living, such as self-care tasks, showering, dressing, grooming, brushing their hair because they can't reach their head with a comb, for example. And then it encourages us to think beyond just the person's immediate vicinity and think about how they interact with their community, how they fulfill their life roles, such as their work roles, their parenting or partnering roles, and their other aspects such as driving or community work. And then feeding into this cycle are also the contextual factors. So the environmental factors, how they live, what the social supports are, and their personal factors. And this includes things such as any pre-existing mental health conditions, drug and alcohol issues, as well as their personal coping styles, which from your own clinical experience, I'm sure you often see can impact a person's outcome as well as the way you might approach treatment. Next slide, please. Thank you. So I want to now delve into a little bit of the research and evidence of what different issues outside of just the medical condition are, and where you might, I guess, request support from your other multidisciplinary team members. So from a diet point of view, we know that cancer can cause a hypermetabolic or a catabolic state, and patients not infrequently experience side effects such as nausea and vomiting and loss of appetite, which will affect their intake of food and water. So it's actually recommended that patients are monitored for the nutritional intake, as well as any weight changes and monitoring of their BMI throughout their cancer journey. On the other end of the spectrum, it's just worth noting that we know that obesity, premorbid obesity, is a known risk factor for development of lymphedema. So we know that patients or people with cancer may require an increased protein and caloric intake. So for example, the standard daily calorie intake recommended is about 25 to 30 kilocalories per kilogram per day, and the standard daily protein intake is about 1 gram per kilogram per day. But for people in a hypermetabolic or catabolic state, this requirement might increase up to 1.5 grams per kilogram per day. So this is where your dietitian, your friendly dietitian, might come in handy because they are able to do their fantastic calculations of what a person's individual calorie and protein intake requirements are, where they are currently and where they need to be or what they need to do to reach their goals for their diet and nutrition. And they're also able to provide examples of types of foods and meals for the patient to reach this. Or if they're really having difficulties with their appetite, they can then recommend appropriate oral supplementations. Next slide, please. Thank you. So in terms of exercise, there's lots of extensive evidence. There are guidelines provided by the Clinical Oncology Society of Australia, as well as statements from the Exercise and Sports Science Australia societies. We know that there is evidence that regular exercise before, during, and after cancer treatment can reduce treatment side effect severity, as well as reduce the experience of a number of side effects, reduce the risk of developing new cancers, and reduce the risk of developing common comorbidities associated with cancer, such as cardiovascular disease, diabetes, and osteoporosis. So these guidelines, especially COSA's guideline, actually encourage all health professionals to discuss the role of exercise in cancer recovery, to recommend that patients follow exercise guidelines, and to refer patients to a health professional specialising in the prescription and delivery of exercise in the context of cancer. Next, please. Thank you. So the COSA's general recommendations include at least 150 minutes of moderate intensity exercise or 175 minutes of vigorous intensity aerobic exercise a week. On top of this, it's recommended that people undertake 2 to 3 hours of resistance exercise of moderate to vigorous intensity a week. And importantly, it sounds like a lot of exercise, but the important part is actually tailoring this exercise prescription to the patient and adjusting it as needed. So throughout the patient's cancer journey, they may need more or less exercise. And it's also helpful to have advice on, their good days or bad days, what they can do to try to maintain their gains and prevent deconditioning and fatigue. Your physiotherapist will also be really helpful in managing those associated comorbidities or conditions. And Dr. Sedaghat did mention some of these already, including loss of shoulder and neck range of motion, adhesive capsulitis or rotator cuff disease, shoulder impingement syndromes or scapular syndromes, myofascial pain syndromes, your usual fatigue and deconditioning, which are not uncommon, as well as some neurological complications, and of course, falls, osteoporosis, and lymphedema. Next, please. So special mention of lymphedema and the role of lymphedema therapists, of course, being a lymphedema service. I just wanted to highlight some of the high-level evidence available for the risk factors associated with development of lymphedema. This includes lymph node surgery, being overweight or obese, radiation therapy, and taxane-based chemotherapy. There is some evidence that supports that physical inactivity, high blood pressure, early edema post-operation, and post-surgical infection may be linked with increased risk of developing lymphedema. But I'd also like to expel some of the myths that we've been carrying around for quite a long time now that don't have much evidence. This includes injections into the affected limb, blood pressure of the affected limb, air travel, and lifting weights. So this is quite helpful because patients often ask about these factors and whether they are at increased risk because of this. So the Australasian Lymphedema Association recommends that all patients being treated for breast cancer should have access to an educational program about lymphedema and a prospective monitoring program for changes indicative of breast cancer related lymphedema, especially those in the high risk group. So those patients who have any of the factors in the high level evidence risk factor list there. The reasoning and evidence behind this, I think, is quite clear. There's a significant cost both financially and to the patient's health and well-being once they have developed and established lymphedema, as well as a cost to the healthcare system with lymphedema being a chronic disease that does carry with it other complications such as cellulitis and sepsis. And we know that with early detection and treatment, there's evidence that the disease is potentially reversible. So if we're able to pick it up during its subclinical phase, it might be reversible. So of course, the role of the clinical psychologist is important. And I actually feel that symptoms of distress and adjustment difficulties are really underdiagnosed in most of our patients, even outside of the realm of breast cancer. So it's important to monitor for these. We know that anxiety and depression are also common. Patients with breast cancer are up to 5 times more likely to develop depression, for example. That's at an incidence rate of about 10 to 25%. And even there are even studies that show that up to 50% of patients with early breast cancer diagnosis actually have symptoms of depression in their first year after diagnosis. So it's not necessarily associated with just severity of disease, it's just the general condition, and we should be all screening for this. There are also issues with sleep disturbance and insomnia sometimes reported, financial stresses, social changes, and of course, issues with self-esteem, self-image, and intimacy. Other things to monitor for addiction and mood swings, as well as post-traumatic stress disorder, even after they've gone through the cancer journey. And don't underestimate the cognitive impact or the psychological impacts that fatigue and cognitive changes of fatigue can have on your patient as well, because they might really be struggling with work or managing the usual day-to-day life roles that they did before their treatment and diagnosis. And we can't forget the partner of the person undergoing breast cancer treatment as well, as evidence shows that they might be up to 40% more likely to experience severe depression. Next, please. Thank you. So I just also wanted to mention the research team, because Alert do have a fantastic research team, and they're present with us at each of our multidisciplinary clinic appointments for data collection. And the data that they collect is relevant for both current clinical work as well as our future research. And by having our research team part of our clinic, we're actually able to perform translational research. So do you know how you have the old filter paddock for your restaurants? This is basically from lab to practice, essentially. And some of the clinical implications we've had with the research that have been coming out of the Alert service includes improving our understanding of the superficial lymphatic anatomy, so understanding the drainage pathways, as well as the common compensatory pathways, especially in the setting of breast cancer lymphedema. And we use the indocyanine green lymphography tool, which I've actually found personally patients have really liked, because it gives them a real-time educational opportunity to understand lymphedema as a condition and to see what's actually happening in their body. And it's also helped us enhance management strategies. So with the lymphedema therapy program that we run here, it's really shaped the way that our service teaches manual lymphatic drainage, for example. And the research has also had implications on early detection and management of lymphedema. Next, please. So a special mention to any of our medicos online today. The role of the doctor, as Dr. Sedaghat has mentioned, is not just, for example, for the surgeons in the operating theatre, but also includes screening for early detection management and referral to the appropriate multidisciplinary team members to ensure that the person remains at the centre of their care. So we want to monitor for complications, some of which I've listed there. And there's also an important role. Actually, I'd like to extend this not just for the doctor, but for all of the multidisciplinary team to maintain liaising and coordination between each other, to be able to make sure that there's no, I guess, missed issues for the patient. And this also includes not only liaising amongst ourselves as healthcare practitioners, but also making sure that the patient and the family understand what is going on. And I really believe that patient education is really empowering for them. Next, please. Thank you. So finally, I just wanted to mention some ways that patients can access rehabilitative care. So firstly, once you've identified what the person's rehabilitation issues are and what the possible needs are, it's important to determine who will be the main person or the key person managing and coordinating the rehabilitative care. It might be the breast cancer surgeon, the primary care physician, the oncologist, or in those who have lots of complex needs, it might be helpful to have the input from a rehabilitation physician to, I guess, offload some of those responsibilities as well. Next, it's important to look at what funding and resources are available to yourself as a clinician, as well as available to the patient. So I've just listed here a couple of different options. The Medicare options are mainly for our primary care physician friends to consider if they are wanting to manage rehabilitation care in the community. And then the public and private options here listed include different ways that patients can access therapy in both the public and private settings, whether it be inpatient or outpatient settings, depending on their needs. And don't forget, there are also specialised public hospital services through palliative care services, as well as my aged care services for those over the age of 65. And in some local health districts, there are hospital in the home or rehab in the home services available, where the therapy is brought to the patient's home directly. And finally, we need to think about closing the loop and making sure that there's continuous communication and continuity of care for the patient throughout their cancer journey, essentially from beginning to end, and even after they've finished their formal primary cancer care. And I think that's it from me this evening. So I'll pass on to Fiona. Thank you.
Many thanks, Steph. A really interesting presentation. It's my privilege to, just staying on the first slide, Louise. Thank you. It's my privilege to present a lymphedema therapist perspective on what's important and how to implement a multidisciplinary approach to surveillance for lymphedema as part of breast cancer rehabilitation and survivorship. It can be said that Australia is leading the way in this, even though in Australia we have both public and private health systems delivering breast cancer care. Our healthcare system does allow allied health professionals to initiate this model of care, and so we've had this ball and we've run with it. And this is of huge benefits to our patients, but it's also a huge opportunity for us as allied health lymphedema professionals, as there's a whole new patient population we can reach with this model of care. Next slide. So let's talk about what this model of care looks like. Next slide, please. Firstly, it's clear that all individuals should have access to this care, and we'll shortly look at the evidence. It's important to recognise, as we've discussed, that this model of care should be delivered within a multidisciplinary team that includes breast surgeons, oncologists, radiation oncologists, rehab specialists, breast care nurses, clinical psychologists, physios, OTs, exercise physiologists, dietitians, and in addition to lymphedema therapists. This doesn't mean that you have to sit formally in a breast cancer MDT to deliver this model of care, but you do need relationships with breast surgeons in particular, as they're generally, as Dr Sedaghat mentioned the first specialist medical contact an individual with breast cancer encounters. Once you're conducting surveillance, then your relationship with the other multidisciplinary team members is vital. We want to be able to address all the survivorship goals of our patients. We should recognise we can't be experts in everything. So if your expertise doesn't lie in dietary guidance or exercise prescription or musculoskeletal rehabilitation, then you need to build connections with other health professionals who can team up with you. The aim of the prospective surveillance model is to detect subclinical stage 0 or early stage 1 lymphedema. This impacts long-term outcomes. We don't want to shortchange our patients in not offering them this opportunity. It's less burdensome on the individual to manage the early intervention protocol than to manage lifelong established lymphedema. Next slide, thanks. So why do we adopt this model of care? Next slide. The protocol for this model of care is supported worldwide. As we're largely an Australian audience, I point out that as recently as February this year, lymphedema therapists Helen Borsinos, Gillian Buckley, Lizzie Eastwood, Lisa Parry and Teresa Lee published 5 facts about risk reduction and early intervention in lymphedema through the Physio Research Foundation, supported by the APA. And this identified that evidence supports early surveillance as integral to the risk reduction process. We have more than 20 years of research to support this. Next slide. I'm not going to examine the data here in detail, but the first study on this list, led by Robin Box, was in 2002. So in fact, that's 21 years of published research. Next slide. These trials vary in protocol. Some use bioimpedance spectroscopy surveillance. Some just utilise tape measure circumferential measures, but they include large populations and randomised controlled trials. And this literature overwhelmingly supports this model of care as it delivered better outcomes for individuals at risk of lymphedema. Next slide. So what's the protocol for early intervention? And this is based on the PREVENT study, which was a multi-centre randomised controlled trial. So surveillance was used to detect stage 0 subclinical lymphedema, which is an LDEX of more than 6.5 or greater than 7 LDEX points from pre-treatment baseline, or an increase in circumferential measures of greater than 5 and less than 10%, and that triggers early intervention. This included prescription of a class 2 compression sleeve and gauntlet worn 12 hours a day for 28 days. If the LDEX returns to a sub-trigger level in the PREVENT trial, the sleeve was removed. There are a few things I like to consider when prescribing this type of sleeve. I actually find it one of the most challenging to get exactly right. So if my patient doesn't fit completely into all the sizing ranges for the ready-to-wear circular knit sleeve, I don't hope for the best and prescribe it anyway. Sometimes this actually means prescribing a custom-made sleeve, and if I do need to go for a custom-made sleeve, I would always opt for a flat knit fabric. I do use a gauntlet. Since the pandemic, I don't use a combined gauntlet and arm sleeve, but rather 2 separate garments. This makes removal for hand hygiene much easier. This is again why fit has to be perfect. Where the gauntlet overlaps the wrist needs to be a gentle fit. Otherwise, I'm always concerned about causing hand swelling. And so skilled measurement of this type of garment is vital. If you plan to implement a surveillance and early intervention program, then ensuring you have both an appropriate surveillance protocol and staff trained to measure and fit compression sleeves is one of the important steps to have in place first. I also wouldn't necessarily remove the sleeve after 28 days. This is where the clinical reasoning and risk stratification are considerations. My decision depends on the current breast cancer treatment status of the individual. There are other risk factors for lymphedema. It depends on the weather. Hot, humid weather wouldn't be the time that I would choose to remove the compression gradient compression sleeve. Next slide, thanks. So apart from the actual measurement and prescription of a compression sleeve, what are the other things you need in place for a surveillance program? Next slide. Bioimpedance spectroscopy measurement is an easy way to assess for subclinical lymphedema, and the information as presented on a SOZO pictured here provides a clear graphic to help you in educating your patient as to why you're suggesting they start wearing a compression sleeve. This device is simple, quick to use. It doesn't always have to be the lymphedema therapist who performs these measures either. The breast care nurse can take the measurement. Anyone can be trained on how to take a measurement. In the PREVENT trial, the patients took their own measurements. The important thing is to have the protocol in place of what to do if the LDEX triggers the need for early intervention. I recognise that not every clinician has access to bioimpedance. Early intervention can also be triggered by circumferential measures. Without LDEX, I think our education to those individuals being screened becomes extremely important, teaching them to identify early signs of lymphatic compromise alongside routine measurement with a SOZO or with a tape measure is the opportunity to drip feed this education to patients, along with the risk reduction advice that should always be included in early intervention. The second half of this slide is really to show you what we're trying to avoid here. Established stage 2 lymphedema imposes a huge burden on the individual and on the healthcare system. We know early intervention can prevent progression to this type of lymphedema. Next slide, thanks. Other considerations to have in place. We've discussed the need for a collaborative multidisciplinary team and the importance of the monitoring protocol and the action plan if the trigger is reached. Educate your team and your referrers on when you want to see people and how they can routinely access screening. There may only be a short lead time between initial surgical review, biopsy, and commencing treatment. So think about when you need to be available to offer that baseline screening. Look at the funding and resources you need for equipment and staffing. A SOZO device is wonderful, but if you don't have the intervention protocol, you're not going to get the outcomes you need. Another thing, it's important to evaluate what you're doing, collect the data on who you see, review the outcomes you're achieving, and feed this back to your referrers and to your MDT team members. Next slide, thanks. This is the monitoring protocol. The pre-treatment baseline can be the hardest to access without a referral pathway from a breast cancer MDT. Given the increasing use of neoadjuvant chemotherapy, we ideally want a baseline prior to the commencement of chemo. Sometimes this doesn't happen. We want the baseline as soon as possible, ideally within the first 3 months of commencing treatment. The 3-monthly repeat review is recommended for the first 1 to 3 years. This is where I think we need to risk stratify our patients. I don't see my low-risk patients every 3 months for 3 years, but for high-risk patients, I would aim to see them more frequently in the first 12 to 18 months and reduce frequency if they do not show any signs of a compromised lymphatic system. This time is gold for your patients, as this is the time to educate them on risk reduction, screen for musculoskeletal issues, assess scarring and breast edema, and empower them to really take hold of their breast cancer rehabilitation. This is what I meant by the opportunity that this patient population presents to us as clinicians. We don't always have to be treating severe established lymphedema. There's a majority cohort out there who don't develop lymphedema, but that does not mean that they can't benefit from comprehensive rehabilitation post breast cancer treatment. Next slide. I think Stephanie already discussed this. I'm sure we're all familiar with the many things that people have been told to avoid, from lifting heavy objects to blood tests, blood pressure monitoring, and aeroplane travel. In terms of the evidence-based risks, axillary dissection is a higher risk. It's important to remember, though, you can still develop lymphedema following sentinel node biopsy. You also want to consider the other risk factors. They include regional node irradiation and taxane chemotherapy. Additionally, post-surgical infection and episodes of cellulitis increase risk. A BMI over 30 at time of diagnosis has been shown to be a risk, as has living in a rural location. So think about these things when evaluating your patients in terms of the review window and frequency. Next slide. Again, I want to emphasise the importance of drip feeding education to your patients during the surveillance. Educate them about skincare. This is straightforward. Educate about exercise. Once more, if you don't feel it's in your scope to provide guidance, then work with someone who can. I've mentioned the COSA guidelines here, and we've already heard those described. But I really think that we do these individuals no favours if we do not emphasise the importance of exercise in this patient population. We absolutely must take into account the stage of treatment and comorbidities, but our end game should be a lifestyle where exercise is a routine part of self-care. The difference that I see in the clinic when examining individuals with lymphedema who engage in weekly vigorous exercise versus those that do not is vast, and actually undertaking vigorous exercise has meant that some individuals, in spite of ICG diagnosed significant lymphedema with very altered lymphatic architecture, can manage with minimal garment wear. The other thing to consider in your drip feed is evidence-based guidelines regarding risks of IV access and blood pressure assessments. I point to the current Australian-New Zealand College of Anaesthetists guidelines here, and the first is a recommendation for shared decision-making between anaesthetist and patient. Empower your patient to be able to share in the decision-making with education. The guidelines include the removal of universal precautions that relate to patients who have a history of axillary dissection. For patients with that history who don't have lymphedema, there is no contraindication to non-invasive blood pressure monitoring, IV cannulation, arterial line insertion. For patients with lymphedema following axillary dissection, an alternative site should be contemplated where practicable, considering the relative risk associated with more invasive procedures. There's no absolute contraindication. Discuss this with your patients. This is an area where there's plenty of debate and concern on behalf of patients. So ensure you can provide education on the risks that they can control, such as the amount of exercise that they're doing. Next slide. In conclusion, my message is that this model of care is supported by evidence. It's an opportunity to empower those individuals at risk of lymphedema to improve their own outcomes. It works best with a multidisciplinary approach. And I believe this model of care should be translated to all cancer groups so that all individuals going through cancer treatment and at risk of lymphedema can have access to this care. Thanks. And now I'm going to hand over to Mandy.
Thank you, Fiona. Fantastic presentation. It's really, really interesting. So I'm really pleased to be able to just talk briefly for a few minutes about the importance of a well-fitting garment. So obviously we at Medi were really happy to provide the compression garments for the PREVENT study, and you know, compression garments are our thing. So next slide, please. So you might think that just measuring is the most important thing, but I really feel that given what we've talked about in terms of a multidisciplinary and a holistic approach, it's really important to get that well-fitting garment, because this maybe their very first, is probably their first experience of compression, and they're already going to be stressed about what they've already had to experience. It's an important time for them. This is an additional stress factor on top of already an already emotionally charged time. So their first experience of compression is really important. So if an ill-fitting sleeve goes on, or a ready-to-wear sleeve that doesn't fit them properly when they need a made-to-measure sleeve, it puts them off from the start. And I think that's really important. It's already hard. We've already heard about how a lot of patients are experiencing depression and image issues. So getting the right garment is really important. So also, the better the fit, the better the management. So the flow of lymph is better if the fit is better, and also in terms of comfort and consistency. If the garment's more comfortable, then they're more likely to wear it, and they're more likely to get consistent compression with a well-fitting garment. The other important thing about a well-fitting garment is to have personalised options. So everyone is unique, as we've talked about, and has different needs. For some people, having a separate glove and arm sleeve is really important. For others, they really don't want that. For some people, a colour is a really good option for them. They feel like it helps, and for others, it's absolutely not. So I think it's really important to have all of these things in our minds when we're looking at compression garments for patients. Next slide, please. So in terms of what Medi has to offer, we have a ready-to-wear range, which is a round knit and a flat knit. So we have Harmony, which has our round knit with 14 different sizes. So that gives us a wide option, so standard and a wide option in both class 1 and class 2. And we have seamless gloves and gauntlets. And our colour range is caramel, sand, and now black. We've just introduced a limited range of black garments because we've been asked for those for some time. So that's quite a good amount of sizes, and because it's circular knit, it's pretty easy to fit and wear, and is quite comfortable. And we also have our Mediven Esprit, which is a flat knit garment, and that comes in 10 different sizes and has a long option. So usually between the Harmony and the Esprit, you can find one option which works for your patients. Class 1 and class 2 again, and glove options. But we also have a very large made-to-measure range, and that's where I think it's really important to be, if possible financially, and if possible, if they don't fit into a ready-to-wear sizing, really to talk about the importance of a made-to-measure garment, and that it is made to fit them perfectly. So we have the Esprit fabric and the 550 fabric, which is, the 550 is our got our greatest wall stability. So it's really a fantastic fabric for those people who are having some issues, like if they already have some obvious lymphedema. So with our made-to-measure garments, you've got so many options, so many different colours and patterns, and options around linings or pockets or flexure functional zones at the elbow, etc. And we can do all-in-one arm sleeves with glove attached or separates, and we can tailor make those garments for issues such as, you know, if you have this tendency for fluid to flush back into the hand, we can make the garment with this porous section on the overlapping glove, so that it only has compression in every other row. So there's lots of different options. You can put lymph pads on top of the dorsum of the hand, and there's lots of different top band types of options and scenarios. So it really does give the patients a more personalised garment, and can be tweaked and altered to suit them. So yes, that's really what all I have to say. You know, obviously we can be contacted for further information, but just to say that we do have a good range, and it's important to have a well-fitting garment. Thank you. And I'll hand back to Louise.
Thank you very much to Mandy, to Fiona, and to Negin and Stephanie for that excellent presentation. If you want to scan those QR codes, we encourage you to follow us on LinkedIn and hear about our latest activities. But now I would really like to stop sharing my screen, invite all of our speakers to join us on this panel session. And I want to open the floor to the people who have joined us live this evening to ask questions. Unfortunately, Dr. Stephanie Lam had to leave us, but we have got Dr. Negin Sedaghat, breast surgeon, Fiona Tisdall Blake, lymphedema therapist, physiotherapist, Mandy Galbraith from Medi Australia, and I'm here to facilitate and lead questions. And please put your questions into the Q&A function. And while the first person is putting those questions in, I'm going to start with the question to you, Negin, as our breast surgeon extraordinaire here at Macquarie. I didn't say earlier that Negin did train as a physiotherapist also before coming as training as a medical practitioner and then a surgeon. So we are so fortunate to have two medical practitioners who know what allied health professionals are and do. So grateful to have you here tonight, Negin. And I know when we talk about this subject in a lot of our training courses, and I get emails all the time, that in Australia, health professionals do tend to understand this model of care of prospective surveillance and early intervention in breast cancer. But the challenge a lot of therapists say to me is that how do we implement the model of care? How do we get the breast surgeons on board? I might be a lymphedema therapist and want to conduct this model of care, and I want to measure all the patients, but how do I get the breast surgeon to help me? And I know you've got experience in the public and the private hospital setting, so maybe if you start with either public or private, and help give us some insights into the minds of breast surgeons and how we can support you in your role as a breast surgeon to implement this model.
I think that's a really great question, and it's so multifaceted as well, because I think it comes down to the really big challenge that everyone faces regardless of any innovation that we partake of within surgery or healthcare, which is that of changing culture as well. And I think it's really important to have a multifaceted approach. And certainly for me, it was, and you alluded to my history of first starting off in physiotherapy. I think that really helped me a lot, to be honest, because I started off my medical career and throughout into surgery with that multidisciplinary mindset, and a real life example of how much multidisciplinary care provides value to patients in their care as well. And I think the main thing is that it really requires, firstly, just a natural interaction with the multidisciplinary team. I find that multidisciplinary team journal clubs really help, because it brings everyone together in the same space, and all of a sudden it enlightens everyone's understanding of each other's expertise as well. I think that surgeons in particular really respond to hard data about their patients. I think if a surgeon were to be aware of the incidence of lymphedema after axillary surgery, to be aware of the burden of disease of, say, lymphedema or another aspect of multidisciplinary care, and the effect of the intervention on that, it completely changes the perspective and the outlook And then it's about really understanding the reality of that context, because we're really fortunate in private care at Macquarie to have everyone on site. Like, multidisciplinary care is just such a natural part of the process. And in a context in which there isn't integrated healthcare, and it's really difficult to coordinate multidisciplinary care, or for patients to participate in multidisciplinary care, because they have to go from one side of the city to the next side of the city, then that's a really fundamental thing to work on as well, like to make it user accessible so that people can take it up. And then also in terms of education, it would be really targeting the newer generation that's coming through as well, and instilling these values of care into every generation. Yeah.
Excellent answer, Negin. Fiona, have you had any challenges when patients come to see you and say that they weren't introduced to this model of care early enough, perhaps, that they've come from somewhere elsewhere, they hadn't been offered this, they've got a problem, and now they're seeing you as a lymphedema therapist? What advice do you say to those individuals about educating perhaps their own members of their multidisciplinary team?
Louise, you do allude to the circumstance that I'm sure we all have encountered in treating someone with lymphedema, in that the number of patients who've said to me, if only I knew beforehand about this, they can be quite upset that they didn't get the chance to do anything about it beforehand, particularly when this is not a new concept. Early intervention and surveillance isn't a new concept. But I've spoken to the multidisciplinary team at Macquarie, and I recognise that I think one of the concerns for surgeons in particular is not wanting to overwhelm patients at that initial appointment when they're the ones having to deliver that really challenging and confronting news to the patient about their breast cancer diagnosis, and then not wanting to overwhelm them with the lymphedema story as well. So I think it's I don't think that's an easy path to navigate. And I guess for lymphedema therapists, then talking to surgeons about how to at least deliver that information so that the patient knows that they can access surveillance and screening without being terrified by the sort of potential consequences of lymphedema. I think it can be done, but I think that is a challenge. And I had something else I wanted to say. I know. And the other thing is, I think the feeding back the outcomes of surveillance is really important, and just letters back to surgeons, referring surgeons in terms of status about someone who's undergone surveillance but hasn't developed lymphedema, but also about the people that do go on to develop lymphedema is a really important way of trying to help to improve that access.
Thanks, Fiona, and keep those questions coming in. Please type your questions into the Q&A function. If you want to say your name, and happy for me to say your name and where you are, you might want to put that in the question as well. So thank you. I'm going to get through all of those questions. We've got time to be able to do that. Maybe, Negin, you can give us any tips or tricks of advice of how perhaps allied health professionals or lymphedema therapists should, how you suggest to your patients about seeing an allied health professional, whether it be for lymphedema or for some aspect of multidisciplinary care. How do you phrase it to your patient when perhaps, as Fiona said, they are stressed? It's quite a stressful time for them. How do you phrase it?
Yeah, so my approach to this, and I actually did want to do a natural follow-up to Fiona's comment, was really to make it part of the standard of care. that this isn't something that I'm referring you to for because I'm concerned, but it's something that I refer as a standard for all of my patients. Patients are really reassured by that. And I think it really alludes to that whole concept of being thorough and providing comprehensive care. And when it's framed in this way, the fear element is really removed, because it's like, okay, this is a standard part. Every patient is referred to a dietitian, a physiotherapist, and a psychologist. And this is part of my journey. It's not anything else that is a red flag for anything, but it's part of my holistic care to make sure that I get the best out of my therapies as well. So that's how I really phrase it. And I haven't had a patient be worried about that at all so far. But
Don't we all want a Dr. Negin as part of our multidisciplinary team? So Leah has sent a question in and said she's found that the breast surgeons are quite happy for their patients to have the interventions of allied health, and they know the benefits, but they want the referral procedures to be embedded rather than having to think of referring their patients themselves, which you're saying you haven't embedded. So what would your advice be to Leah and others with that same situation?
Look, I think that alludes to a possible process within the system that can facilitate this. I think that that's a really great idea if it is somehow automatically embedded. But at the same time, I really think that there has to be a conversation in that initial consultation. And it kind of humanizes it, and it allows the patient to know what's coming in terms of the referral, perhaps. And it conveys that other less tangible aspect of care as well, if we bring it up to patients. And I think a simple sentence or a one line goes a long way, because we have to keep in mind that if the surgeon tells the patient that this is really important, it makes it really easier for the allied health therapist who comes in, because the patient is sort of told right from the beginning, all these people are important for your care as well. But I think that suggestion of having it embedded within the system is brilliant as well, because it will facilitate anything that makes it easier is definitely a fantastic addition to have. Yeah.
Right. Thanks, Negin. Got a question for you, Fiona. Thanks for today's session. This person is saying, when using ImpediMed's SOZO BIS device, how concerned are you when negative changes occur? She feels confident in understanding the positive changes, but not really understanding the processes occurring when patients display negative changes.
I assume, and please clarify in the comments, that what you mean is that the LDEX that you're monitoring is actually getting lower. I'm assuming that's what you mean.
That's how I would take it, Fiona.
Yes, and bearing in mind that your LDEX, the normal range is from -10 to 6.5, so anywhere in that range is normal. Then what you have to think about when you're looking at those LDEXs, or for a particular individual, is you've set their at-risk limb if you're doing a unilateral measure, which is what you're using generally for breast cancer surveillance, because you put the at-risk limb in, which is the side that they've had their surgery and auxiliary surgery, dissection or sentinel node biopsy. Then if their LDEX is going down, what you're looking at is the ratio of fluid between their at-risk and their not at-risk limb. And so the LDEX going down means that there is more fluid in the other limb compared to their at-risk limb. Now, what are the causes for that? It could be due to the chemotherapy that they're undergoing. It could actually be a difference in volume between their two limbs for people where their dominant arm is very different in size, often that arm will actually have a slightly higher LDEX normally. And so then if you're adding that into an at-risk or a not at-risk arm, you really actually have to look at the patient. An LDEX is only a number. You've really got to put it in context of what's actually happening to your patient. So looking at their arms, have they had any change in terms of their fluid levels from other medical conditions that are going on? Have they had some sort of IV access or lines or chemotherapy access on their other limb that could be causing the LDEX, the fluid, the extracellular fluid to increase on their other limb, which is then giving you that dropping or falling reading of their at-risk limb? I think that's what might be happening, and that's where you really need to understand it's a ratio that you're looking at, a ratio between two limbs. Louise, you're also an expert on this. I hope I've explained that clearly enough.
You've answered it really well, Fiona. And that question came from Angie, and Angie in WA. And Angie has said, thanks so much for that BIS explanation. It's what she was suspecting. So good answer, Fiona. And I would just add that the BIS is measuring total body water in your whole body. And then, as Fiona said, comparing the at-risk to the healthy limb. And it's normal for changes in total body water, depending, what the weather's like, what you've eaten, different things. Like if you stand on the scales every single day and you eat the same thing every single day, you will get fluctuations. The same with the BIS reading, you're going to get some normal fluctuation. So thanks, Fiona. Keep coming those questions. Please put questions into the Q&A function. I've got a question for you, Mandy. Mandy from Medi, in her beautiful pink background there, Mandy. Just a question about washing compression garments. Can you just give us a bit of information about care and washing regime for compression garments and why they do need to be washed regularly?
Yes, thanks, Louise. So washing is actually sort of a bit easier than you might think. They can actually be washed in a washing machine at a low temp with other garments on a sort of delicate cycle, or they can be washed by hand. I think one of the main things is not to use softeners and not to use sort of eucalyptus-based, sort of oil-based washing detergents, because they can damage the elastane and the polyamide fibres over time. So it is really important to wash the garments very regularly. In fact, every day or every other day is best, because they keep their shape better, and they just retain their compression and shape much better if you do that. And so having one to wash and one to wear is the best way. And they can be dried in a very light dryer as well, in terms of not a really hot one, but light or flat, but not in sunlight. Again, bright sunlight, which we do get a lot of in Australia, can damage the elastane fibres. So it's relatively easy, even just to wash them, rinse them out with just a bit of hand soap, and they don't need a huge amount of washing if they're being washed very regularly.
Great, thanks, Mandy. Another question for you, Negin. Do you feel that there are some patients out there that get super anxious about lymphedema and who potentially may even be at low risk, and how do you manage that in your practice?
Yes, absolutely. I have to say it is rare though, but I have come across patients who are incredibly anxious about that. I think it comes down to the education and the consultation, and with those patients, I actually utilize my breast care nurse in that for further counselling and follow-up, and it's access to correct information to So in that setting, I really do stress to them to first follow up with a lymphedema therapist, that they can be informed, they can be reassured. In that way, they sort of gain a bit more confidence by knowing that they're being assessed preoperatively and that there's a plan in place at certain intervals to then be assessed again. So it's not like we're acknowledging this as a risk, but not actively trying to identify early if it does occur. So that is my approach in those patients. I've not yet had a patient after that who so refuses to proceed with axillary surgery, but it requires a number of consultations before surgery to get to that point, I think.
Great. Thank you, Negin. Another question for you, Fiona, and it's again relating to LDEX. So could the drop in LDEX from pre to post axillary dissection be due to improved flow out of the affected arm due to removal of the diseased lymph nodes, especially if the LDEX was high? For example, an LDEX of 12 pre-op, then dropping to 7 post-op. How would you explain that?
Well, I think we don't have the sort of full knowledge of that, but I actually think that's, as a hypothesis, I can think that that is potentially possible, because I think we can detect palpable sort of lymphedema in someone who has a lot of obstructive disease in their lymph nodes pre-surgery, but I don't know that, I haven't read anything about actually the LDEX dropping because you've removed the obstruction from the lymph nodes. But I guess as a hypothetical concept, I can understand that that could happen. Again, Louise, as I say, you are the expert in this too, and I don't know whether you have actually read anything that's actually demonstrated that.
No, I just support what you've said, Fiona. I think I have seen patients with a high LDEX before surgery, and generally they've often had disease in the axilla. And so after surgery, or sometimes after neoadjuvant chemotherapy, that the tumour shrinks or the tumour is removed, and so then we do see the LDEX come down. So, you know, that's a good thing, and that's where you need to be cautious of your pre-op reading. And as Fiona highlighted, I think we really now emphasise pre-treatment baseline measurements, ideally, whether it's by BIS or the tape measure. Don't forget also what the individual patient is talking to you about, the symptoms they're feeling. There's some, you know, emerging research coming out about, you know, the symptoms that people are identifying that may then correspond to the BIS reading. So be aware of that as well. I have a question here about breast edema. So we didn't actually cover that today, but Negin, I'd like an input from you about how you educate and manage breast edema from a breast surgeon's perspective. And then I'll ask you, Fiona, to give any input. And then I'll ask you, Mandy, whether you have any options in the Medi range. Over to you first, Negin.
Thanks. Look, I see breast edema more commonly, not so much after axillary surgery. Certainly I have seen it after an axillary clearance, but more commonly I do see it after breast radiotherapy as a phenomenon. And certainly in patients, I think because there's less sort of awareness or education around breast edema, that they're not aware that their symptoms are due to the breast edema. So the pain that they're experiencing in the breast can be managed by simple massage techniques as well. So when it comes to examining these patients, it's very clear that they're suffering from breast edema, and unfortunately, patients continue to suffer with the pain for quite a while until then they come for their follow-up review. And so that's why actually quite recently I had changed my practice to include a discussion about breast edema. And it's actually really simple massage techniques that any breast cancer therapist or specialist that's involved in the care of the patient can teach to the patient. And it can be very empowering and something that can alleviate a really significant symptom like breast pain. Yeah.
Great, thank you. So am I taking from what you're saying, perhaps you're blaming the radiation oncologist for causing the breast edema?
I am actually.
We won't send
But
that.
maybe that's my bias as a surgeon. Like I said, you know, this is also something that perhaps surgeons and myself included aren't aware of exactly what is the burden of breast edema after axillary surgery. We speak so much about the lymphedema in the arm, and I think now there's space to learn about this as well. So you're right, it might be a little bit of bias on my part.
Thanks, Negin. So Fiona, I'm sure you see breast edema in the clinic often. Can you describe how you approach the assessment and management of breast edema?
Well, I think that as part of your surveillance program, then that's one of the conversations. In that time that you're talking to the individual, when you're doing their routine measurements and looking at their shoulder quadrant function and asking about breast edema, and for people who've had breast conserving surgery, like a wide local excision, then they might be wearing their post-surgical bra. You're not always taking that off to examine them, but I think that actually that you definitely need to ask people about it specifically, not just anything else, but what's it feel like in your breast, and is that uncomfortable, and are you aware of any swelling there, and also then examining their breast for signs of breast edema. I think that, Negin, I support you in your thought that radiation oncologists are responsible for a significant amount of this problem. But the other thing that I would say in my observation is that the beautiful oncoplastic surgical techniques that we see, where these patients have very small scars and they might be tucked away neatly in their axilla, but have potentially had a lot of rearranging underneath the skin, so that sometimes the palpation findings in the breast, it's not just edema, but sometimes you can feel sort of adhesions through the breast. And I'm talking not necessarily in the very early stages of their post-surgical recovery, but further down the track. And so sometimes it's sort of a combination of fascial assessment as well as assessment for breast edema is really an important thing to have a discussion. And that's the nice thing about doing a surveillance program, is you've got those repeat times to address these things, because you don't necessarily want to be covering everything in one session in terms of trying to avoid overwhelming your patient. And I also agree that actually identifying breast edema, and then generally the lymphatic drainage techniques for that are simple, and they can be performed quite easily by the woman who's experiencing the breast edema. So demonstration and teaching and showing people how to do that, it's really effective. And then other things that I use, like textured inserts inside bras to sort of provide some local compression support. Yeah, that's it's certainly an important part of our role as lymphedema therapists to screen and manage breast edema. And I'll hand back to you, Louise, to hand on to Mandy.
Thanks, Fiona. I think, Negin, that you're not out of the woods in the blame game here. I think Fiona indicated that some of the trauma from surgery may actually cause some breast edema as well. So
yes, absolutely.
And
I would
members contribute.
Yeah, and I would say, like, as surgeons, we do consider incision placement as well, like what Fiona was correctly alluding to with the oncoplastic techniques. We're quite mindful of the lymphatic drainage pathways of the breast, and certainly in upper outer quadrant surgery, that's when we do get most concerned, and certainly there's room to sort of alter incision placement and things like that in that setting. Yeah.
Great. This is great multidisciplinary work. And Mandy, can you share, are there any Medi products that you recommend or have for breast edema?
Yes, thanks, Louise. We do have the Lymphomed bras, and we do have the lymph pads which can be inserted. So we've got 3 different types of lymph pads, which have ones with large dots and smaller dots and ridges, so they can be used for inserting inside the garments. We also do have a Lymphomed like vest, full vest, either with full sleeves, and there is actually some work at Medi going on at the moment, producing a more sporty looking kind of vest type, t-shirt type looking garment for torso, breast, and axillary edema. So yes, watch this space.
That's good to know, Mandy. And I think early detection, early intervention, not only for arm lymphedema, but for breast edema is really important. We've got 2 questions left, and then we will wrap up this session. A question for you, Negin. Your opinion that too much emphasis in general is put on lymphedema in the arm than to breast edema or chest wall or subaxillar edema. This person totally agrees with you, both from a lymphedema therapist and breast cancer manager point of view. So that's a positive comment to you, Negin. Someone would like to know when you're coming back to WA. Mandy, the question is to you, when are you coming back to WA? Have you got any plans?
Oh, well, actually, funny you should say that, because our managing director, Alex, I think is going to be coming over in May. So I might come a little later in the year, but yes, we will be over. But I've been running some workshops nationally, so on flat knit made to measure workshops, so happy to come over.
Great. Well, Fiona and I are going to be coming to Perth in June this year. So we're going to be delivering a lymphedema accreditation program in June, and also a management of head and neck lymphedema in June. So anyone wants to travel to Perth, or those local to Perth, we will be there. We're also going to New Zealand, and we have our accreditation program in Sydney in July, and also a head and neck and wound management in April. So look up our website for further details. I've got Yanka just joined us and wanted to thank us for the information from Darwin. Fantastic. And there's just one last question before we finish. Are there any differences in the management of women and men with lymphedema post-breast surgery? I guess we haven't talked a lot about men going through breast cancer treatment, but does anyone identify, either Negin or Fiona, any differences in the management of women and men with lymphedema post-breast surgery? And that question's from Ali Reid.
I'll start off. In terms of screening for lymphedema, then I think the protocol that I described, the routine surveillance, the education, the assessing the upper quadrant function, and looking at fascial mobility, scapular mobility, and considering exercise guidance for rehabilitation. I think these things can be implemented for men and for women. I wouldn't have a difference in approach in terms of the way I structured a surveillance and early intervention program for male breast cancer.
Great. Any comments from you, Negin?
Yeah, just remember that in men, they do tend to present at a much more advanced stage. simply due, one, to the biology, the most common biology of the tumour that affects men, but also the late stage at diagnosis. So commonly men do progress, and they account for a small percentage of cases, but still within that small group, it is more frequently observed that the men will progress to an axillary lymph node dissection. And so lymphedema counselling preoperatively, assessment and follow-up with a lymphedema therapist is absolutely crucial in those situations as well. Yeah.
Great, thank you. On behalf of everyone who's joined us either live or to watch the recording of this session, I'd really like to thank our guest speakers for tonight who've really put in a lot of preparation and thought and had engaging presentations. So thank you to Dr. Negin Sedaghat, to Dr. Stephanie Lam, Fiona Tisdall and Mandy Galbraith from Medi Australia. I'd also like to thank my colleagues sitting next to me, helping me with the Q&A, Robin Blumfield from our education team. And we just really appreciate the support that everyone provides us here at Alert, and welcome you to continue joining us for other education events and keep up with the networking. Follow us on LinkedIn, and happy Lymphedema Awareness Month to everyone for the end of March. Thanks, everyone. Good evening.